Hello and welcome back to yet another session with Conceptual OBG. Today, as a part of the current ongoing ERT sessions that we are shooting with Conceptual, I have come ahead with a topic that was a part of my obstetric practice until now, but the advent of ART in my life has given me a new perspective towards it. And I thought, why not just share it with you? So the topic is going to be Ovarian Hyperstimulation Syndrome, or what we simply call as OHSS. So if I have to look back at what was my initiation to this topic of OHSS, then I remember that during my residency, there was a certain emergency evening in my second year of MBBS when we had gotten a patient who was referred from a private center with dense ascites and pneumothorax and all basic signs of third space loss. And we tried to decipher everything, and the patient was just keeping on concealing something. It just felt like there was something off about it. We tried to look at all the causes and everything. She was from a very low socioeconomic strata, and we tried to decipher everything, and eventually we just had to settle for the diagnosis of that maybe it is just something spontaneous, but it was still not fitting well, especially because he was beta HCG negative, UPT negative. So even like had it been she been a positive patient of it, with the history that she was giving, it would have looked at I would have looked at it as an ectopic pregnancy with abdominal collection and everything, but no, nothing. On asking further, her husband revealed that she happened to be a professional donor and she had just recently donated oocytes. And I don't remember and I do not wish to go into the details of where had she donated, what were the protocols that were being used, and she had absolutely no papers that she carried with her, and she just said that she needed that money. Now in India, as per the ART Act, this is banned. A female can only donate her oocyte once. It can be only used for one patient, and there cannot be any monetary benefit that is attached to it. But still, there are people who might be doing it. I don't know. I don't want to dwell into it. But it turned out that because of poor stimulation or because of something that probably went wrong or she didn't follow up, she had gotten OHSS, Ovarian Hyperstimulation Syndrome. So welcome to this discussion, and let me first discuss as to why did it happen to her and is it that common? The answer to how common it is something that you will get in a while, and you'll be surprised at knowing the answer as to how common or uncommon it is. But before that, what is the pathophysiology? So what happens, I will just talk about those ART cycles. So in those ART cycles, the aim is to collect as many oocytes as possible. ART is IVF basically. So I have to collect as many as oocytes as possible so that I can have maximum number of embryos, so that I can get a good pregnancy rate once I transfer them. So basically one oocyte pickup or one cycle should give me around 10 to 15 eggs at least, oocytes at least, so that I can have at least 6 to 7 good quality embryos which I can transfer across 2 cycles or 3 cycles and get a good pregnancy outcome out of it. So that's the main aim. So basically there is multifollicular development that happens, and the drugs that we give are the gonadotropins, which happen to be the recombinant FSH or HMG or highly purified HMG. All these things. We give them all these things and they lead to the multifollicular development. Now the problem is not multifollicular development, it is what happens after they have developed. So when they reach a size of around 18 to 20 millimeters, what I do or what we all do basically is we give them a trigger. Now what is the trigger? A trigger is an agent that is going to lead to two things. First is ovulation, and secondly the maturation. What is maturation? So the oocytes which were trapped in the prophase 1 or first meiosis have to go to second meiosis and stop at metaphase 2. So this maturation is very important, and not just nuclear, even the cytoplasmic maturation, increasing the number of mitochondria. All these things is going to happen when I give that trigger. Ovulation, yes, good, but I don't want ovulation because I'll be collecting the oocytes before that. So the main thing is maturation. So I have to give that. So the triggering agents that we have are going to be two. One is going to be the HCG, which is going to be a mimic of my natural LH, and the other one is going to be GnRH agonist. Why GnRH agonist? Because GnRH agonist is going to secrete both FSH and LH. Now, if you go back and refer to one of our sessions, or if you just go back to and refer to that endocrine chart, you see that during the time of FSH trigger, even LH trigger, even the FSH rises. So this is a much more physiological thing that happens with GnRH agonist. But the problem is the half-life of GnRH agonist is very short, which is why there is rapid luteolysis, or the quality of oocytes may not be as amazing as HCG trigger would give me. So HCG is often the preferred trigger, and also because it is cheap, we give it. There's a problem though. In my body, LH has a half-life or a duration of action of only 1 to 2 days. So the surge and its effect stays for 1 to 2 days. But unfortunately, HCG stays in my body for at least 6 to 7 days. So what it does is, all these follicles that are prepared, let us assume that there were around 15 to 20 follicles that were created in each ovary. All these follicles, after giving LH and after the oocytes have been picked up from them, the HCG in my body that has been given as a trigger will stay and it will keep on luteinizing it. The luteinizing action is going to be so strong and so profound, so long, that due to that excessive luteinization, there is one cytokine, or there is one factor, one thing that is secreted in excess because of this HCG, and that happens to be VEGF, vascular endothelial growth factor. Now, this VEGF is going to be triggered in the ovaries itself, and in fact, in physiological patients and physiological cycles wherein there is no gonadotropin, nothing, this VEGF helps improve the blood supply to the endometrium as well as to the corpus luteum. But when it is in excess, it is counterproductive, because what it will do is it will lead to endothelial dysfunction. Now, this endothelial dysfunction will lead to loss of fluid into the third space, and I'll start getting signs of ascites like abdominal distension, pneumothorax, difficulty in breathing, pulmonary edema, pericarditis. All these signs will start occurring. Beyond a point, if it doesn't stop, and this is not going to stop because HCG is going to be there in my body for 6 to 7 days. And socho, there were, let's say, 15 follicles in one ovary, 15 in the other ovary, so overall 30-35 follicles that were made. All of them have now become corpus luteum after giving the HCG trigger. So many corpus lutea, so much of VEGF that has been secreted instead of just one corpus luteum that should have been secreting it. Now this is going to lead to gross dysfunction in my body, and that gross dysfunction is going to result all because of the endothelial dysfunction. Now what this leads to is, it is depleting my intravascular volume. This intravascular volume depletion is going to lead to hypotension. Not just hypotension, it is going to affect my kidneys. There is going to be pre-renal AKI. So there is going to be oliguria and even anuria. So the urine output is going to be reduced. And because of increasing hemoconcentration, there can even be episode of thrombosis, arterial thrombosis, venous thrombosis. So thromboembolism can happen. All these things can be very, very fatal. So what do I do for that? The first thing that I need to do is, everything apart, the patient comes to me, I need to know whether it is, or what is the classification, what is the grade of it. So there are two classifications. In one, there is the older classification as 1 to 5 grades, and the more modern one, or the one that RCOG recommends, contains 4 grades: mild, moderate, severe, critical. In the critical, there is proper organ dysfunction, end organ dysfunction. There is ARDS, there is sepsis, there is thromboembolism, there is pericardial effusion. All of that basically ekdam end ka stage aa chuka hai, that can even be fatal. Rarely does it go till that end. The mild one is so common that even abdominal distension or discomfort, let alone distension, even abdominal discomfort, pain after pickup, because of the bulky, huge ovaries, there is going to be pressure on the pedicles. It can even undergo a little bit of torsion. Not an emergent torsion, not something that you need to operate, but a little bit of twisting of the pedicle. All of this leads to abdominal pain. So any abdominal pain that comes after the pickup because of the ovaries is mild OHSS. So technically, almost every out of 10 women, 8 women get that. So almost every other female, I'd say, or rather more than that, already have mild OHSS. But because this is a self-limiting thing, it's a self-limiting condition, it will limit itself, it will get cured by itself. So most women will not require anything except just monitoring. So what we do at our center is that we call a female back for after 7 days of pickup, and we just do our abdominal scan to see if there are signs of third space loss like ascites or anything, and if there is ascites, how much it is. So just to keep an eye on her, we call her back. Moderate, severe. Moderate, you can still manage on an OPD basis. Severe and critical, we need to be admitted. Now, once I admit, what do I need to go? I know that it is self-limiting, but self-limiting only until mild or moderate. At severe and critical, I might need to do a few things actively. So how do I manage it? So if I go back to my PSM era, I first need to know what is primary prevention. So how do I prevent all this from happening? So the primary prevention is use antagonist cycles. What are antagonist cycles? I've already spoken in the session, is when basically you are starting the patient on gonadotropins from day 2, and you reach around day 6, day 7, and then you start them on antagonist. This ensures that the estrogen levels in the body are pretty low. Now you'll ask me, how do I choose a protocol? So now there are patients who are at a higher risk of getting this OHSS. They happen to be those patients who have excessive LH in them already. What are those patients? Classically PCOS patients who have supranormal levels of LH in their body always. So patients with high AMH, basically many antral follicular counts. Why many? Because of mostly PCOS, or high antral follicular count on day 2 of cycle, that is more than 20 follicles in each ovary, or bit younger patients, PCOS. All these patients with demographic details are going to be at high risk of OHSS. So in them, the first thing that I need to do is I need to prefer antagonist protocol over the agonist protocol. Also, whenever I use the agonist protocol, it is compulsory that I use HCG as a trigger only, whereas in antagonist, I can use agonist as a trigger, which is much safer and doesn't lead to OHSS. It leads to OHSS only in a very, very few percentage of patients. So antagonist cycle is the first primary prevention that you can do. The second thing is choosing the trigger. If you have chosen antagonist, you can give HCG, you can give GnRH agonist both. In agonist protocols, you cannot give an agonist as a trigger, you have to give HCG, so they are always going to be at a higher risk of developing OHSS. So after I've chosen antagonist protocol as a primary prevention, the secondary prevention is going to be to give a trigger, and that trigger is going to be with GnRH agonist. GnRH agonist, if you feel has not given good outcomes in the past, then you can just combine it with GnRH and half dose HCG trigger, which will reduce the intensity of OHSS even if it's to develop in future. Then what you will do is, if despite all this has not helped, then tertiary is going to be to reduce the complications. So how do I reduce the complications? The first thing is going to be, if I have to admit the patient, then I'll be giving her fluids, not over perfusing her, because that can again lead to worsening of the edema, but I'll give her intravenous crystalloids. Those crystalloids can be your NS or your RL, two of the best ones. Then I have to increase the oncotic pressure. I have to try retaining the fluid back into the intravascular space. So for that, I am going to be giving her 20%, excuse me, 20% albumin, human albumin. Now, human albumin has many things that it can do. The most important that we know already is that it's a colloid and it is going to retain the water inside. But apart from that, it is also said to go and bind to all those vasoactive substances like interleukins, cytokines, and most importantly, VEGF. So that albumin will bind to them and will reduce the intensity or further worsening of the condition. So albumin works in two ways. It binds to the vasoactive substances and it increases the oncotic pressure. Again, remember that it is albumin. It's a product made from another human. So there can be anaphylactic reactions. So you have to be very careful. You have to transfuse it very, very slowly. Start albumin. If it doesn't work, give her albumin twice a day. Give it for a week. It's an expensive treatment. Each bottle costs around 5,000 to 7,000 rupees. So per day, the cost can go up to 15,000. So it is expensive. If you think that your patient just cannot afford that, then there is a cheaper alternative. It is an alternative. It cannot be the best thing that you're doing to her. It will be you give her fresh frozen plasma. FFP or cryoprecipitate, they both are also a sort of colloid. You can give it to them. You also get hexastarch and voluven. That is also something good to give, but again, that is expensive. So FFPs and cryoprecipitate can be given, but fluid overload is a major problem, and hemoconcentration is already there. These factors that you're giving, cryo and FFP, can lead to increase in the chance of thromboembolism. So make sure that you're not using it as the first thing to do to her. You tried giving her, you gave it, still not getting controlled. Now I need to step it up a bit further. One of the best drugs that I have right now is going to be a dopamine agonist, an ergot alkaloid that happens to be cabergoline or bromocriptine. Cabergoline, much better. What it does is it goes and it binds to the VEGF receptors. It not just binds to them, it even stops the signaling of VEGF. So basically, even if VEGF binds to the receptor, it is not going to cause any action. So cabergoline is a wonderful agent when it comes to that, and it stops the action of VEGF, which is why it is one of the drugs of choice in OHSS. What is the dose? You give her a dose of 0.25 or 0.5 every day for 7 days. In my opinion, 0.5 for 7 days once a day is enough for her. That is going to significantly reduce your edema. So remember that. Cabergoline given, it is still not working. What do I do? There is one more good drug that we often forget, but is an excellent and very commonly available drug in my ICU, and that happens to be calcium gluconate. The same calcium gluconate that helped you in magnesium sulfate toxicity is the same one that helps you here. How? Because calcium not just increases your calcium levels, but it also has a significant action by reducing the levels of angiotensin 2 in your body through depletion of renin. There is a deep complex mechanism that I wouldn't dwell into. My nephrologist colleagues would do that better, but it reduces the angiotensin 2 production, and eventually even the production of VEGF is reduced. A similar action is given by tolvaptan. Relcovaptan, ये सब जो है vasopressin antagonists है, we don't use them, but theoretically very good to give. How do I reduce it further? Two very good drugs, metformin and aspirin. Metformin is known to reduce the hyperandrogenicity and hyperinsulinemia in my body. That is going to lead to much better outcomes of IVF as well as reducing the chances of getting OHSS. Aspirin in the dose of 150 milligram is going to bind to histamine, serotonin, all these these vasoactive cytokines, and is going to exert. How does it do that? Basically, it's an antiplatelet drug, and all these vasoactive substances are coming from the degranulation of the alpha granules from your platelets. So if it binds to that, the degranulation will be stopped and the platelets will not release all these vasoactive substances. So that's a good way of stopping all these subsequent third space loss and all those endothelial dysfunction processes. So aspirin and metformin, excellent. Again, it is preferable that you start them before. They are not that helpful as a therapeutic thing. As a prophylactic thing, if you start them before, the intensity of OHSS will go down. What if it still doesn't get controlled? Nowadays we are starting to give elagolix or any GnRH antagonist as a treatment. Now how do you treat it? So there is a way that is postulated, not yet proven but postulated. It says that it goes and binds directly in the ovary to the LH receptors. So when it goes and binds to the LH receptors, the HCG can no longer trigger the ovary, and that will lead to stoppage of action or production of VEGF. So that is one of the postulated actions. It is not going to act centrally over here. The GnRH antagonist is going to go and act on the ovaries. The dose is going to be elagolix, tablet elagolix. The dose is going to be 200 milligram per day for 1 week, 1 to 2 weeks it can be given. Still doesn't work. The respiratory depression is worsening. You put her in the ICU, you intubate it. You can do paracentesis, you can do thoracocentesis. You basically keep drawing out the fluids. It is something that once time passes and HCG is depleted from the body, it will start improving on its own. So those 7 days are very crucial. As I come to the end of this session, there is one more type of OHSS that you need to know, the late OHSS. What is that? It is not caused by the drugs but because of pregnancy. So it happens when a patient conceives in the same cycle. So same cycle matlab fresh transfer kiya hai tumne and she conceives. Now the embryo, the implanted embryo itself is producing HCG through the trophoblasts. This goes and activates VEGF, and that leads to endogenous OHSS, or what we also call as late OHSS. Why late? Because it has happened 10 to 12 days after your trigger has been given. So it is not because of the trigger, it is because of the pregnancy. It is much more difficult to treat because you cannot take away pregnancy. The pregnancy is going to continuously produce your HCG, so it can be tricky to treat, and the last resort can be MTP if it doesn't resolve. So that is why one of the ways of preventing OHSS also is to do a freeze all strategy. That is, I freeze all the oocytes I take and I transfer it in the next cycle, so that the complication of fresh transfer and eventual late OHSS is prevented. So that is all about OHSS. You can look about it. There is a guideline, green top guideline on it. It is really good. Also, it is given really well in Gardner. I come to the end of this session. Thank you so much. We have excellent ART sessions that are going on. The next session that is coming up is on adjuvant drugs in ART, which happens to be on GCSF, filgrastim, growth hormone, metformin, myoinositol, intralipid, Bharglobe. Everything is going to be discussed in it. It is exclusively for subscribers, so I would urge you to take the subscription and watch me live. This is Dr. Aditya signing off from this session on OHSS. Keep watching me on Conceptual. I'll see you again.